it is 0 degree, it's straight. And you also look at the talonavicular coverage, mainly for the planning of for adult acquired flat foot. In the normal foot, these are the very important parameters I am going to let you know about diagnosing the Lisfranc injury. The lateral border of the first metatarsal is aligned with the lateral border of the first cuneiform. The medial border of the second metatarsal is aligned with the medial border of the second cuneiform. Any deviation into this suggests a Lisfranc injury. The medial and the lateral border of the third metatarsal is aligning with the medial and lateral border of the third cuneiform. In an oblique view, a medial border of fourth metatarsal is aligned with the medial border of the cuboid, and the lateral margin of fifth metatarsal would project less than 3 millimeter into oblique view of the foot. So this is how, if these 5 parameters are taken care of, you would be able to diagnose Lisfranc injury very easily. There could be something like widening of the intermetatarsal space between first and second metatarsal, between middle and medial cuneiform, would be showing you the Lisfranc injury. The another important parameter is the intermetatarsal space between second and third metatarsal, which is equal to that between middle and the lateral cuneiform. If that is disrupted, that means there is a Lisfranc injury. The another important sign is a Affleck sign. If there is a presence of a small flake like you see here in between this first and second metatarsal space, it should be evaluated as avulsion of the Lisfranc ligament, and you have to go ahead and do Lisfranc procedure. In a foot lateral series, this is how you take the lateral view. In the lateral view, what you see is again talo, first metatarsal line, Mary's line. Normally it is 0 degree. It is very useful for analysis of adult acquired flat foot. In a lateral view, for Lisfranc, you see that superior border of the second metatarsal is continuous with the superior border of the second cuneiform. If it is not so, if there is dorsal or plantar displacement, that means it shows a Lisfranc injury. This is how the dorsal surface of first and second metatarsal should be at the level of corresponding cuneiform. If it is elevated like this, that means it tells you about Lisfranc injury or a mid-tarsal dislocation. These are the signs of hind foot varus which you see on the lateral view of the foot and ankle, wherein you see increased calcaneal pitch, you see fibula which is normally lying here is lying quite posterior, and there is a double talar dome or see-through sign through the sinus tarsi. This is suggestive of heel varus on a lateral foot view. Sometimes you like to take this internal oblique view which would demonstrate this anterior process of calcaneus, cuboid and the lateral ray very clearly. This is how you take it. You also wish to take external oblique view to delineate the medial column abnormalities and injuries. What we do not take in India very commonly are weight bearing views. But mind you friends, the weight bearing x-rays are very important, and each one of us must train our staff or must train our radiologists to take weight bearing views. This is how we take it at our center. And you see, this is a non-weight bearing view which almost shows that everything is normal, but as the patient bears weight, the Lisfranc injury is delineated. In a weight bearing view, AP view, you would also wish to see the talonavicular uncoverage for adult acquired flat foot analysis. Now these are the common weight bearing relationship which you like to see on AP view of foot. First is the Hallux interphalangeal angle. Then this is the distal metatarsal articular angle, DMAA. This is Hallux valgus angle, which is the most important angle we always try to assess. This is the first intertarsal IMA angle. Then this is the metatarsal break angle, and this is the talocalcaneal angle. These are the 5 angles which you see on the weight bearing x-rays. Hallux valgus angle and intermetatarsal angle are the most important one which you look for planning of your hallux valgus surgery. And this is how When you take a lateral non-weight bearing X-ray and a lateral weight bearing X-ray, this is how you will delineate breakage of the arch and adult acquired flat foot. Look at this. This is again a weight bearing view wherein disruption of the arches is there. The weight bearing relationship of the foot which you see on lateral view are lateral talocalcaneal angle. You also look at the fifth metatarsal base height. Again you look at the calcaneal pitch angle and a Bowler's angle. These are all important for you. A typical sesamoid view is taken like this. Had this been taken with Sachin Tendulkar, he would not have missed his injury for a long time. But friends, at the same time, there are inter-observer variations and there are magnification variations and there are patient-to-patient variations. So don't only rely on to plain radiography. You might sometimes need to use stress radiography to assess ligamentous stability. Varus and Valgus test is done at ankle. Anterior drawer is done. And how is done? This is the Tailor tilt stress test, which is performed by tilting the hind foot and looking for a suction sign laterally or asymmetric movement. You call it positive when it is more than 15 degree, side to side difference of 10 degree. You can compare like this. For the ankle instability, there are certain controversies how you do the ankle stress test, but now we have derived that you have to do the ankle anterior drawer test in a 20 degree plantar flexion with the knee hanging or slightly bent. The cutoff limit is, that I said about the Tailor tilt. For anterior drawer test, it is 0.5 to 1 centimeter or side to side difference of 3 millimeter is diagnostic. So this is how you do the anterior drawer test. This is a very, very important test I almost always perform whenever I go in for the fixation of the ankle fracture, and this is called as gravity stress test. It is a Siam guided test wherein you bring ankle off the edge of the table and allow it to fall, and widening of the medial clear space on cross table Mortise radiogram is going to tell you about the deltoid incompetence. So whenever you have doubt about the incompetence of your deltoid ligament, do this test intraoperatively with the help of Siam. Tomography we use very, very rarely to detect certain occult and certain known lesions. It would blur the structures on the either side of the plane to which you are interested into. This is how the tomogram would look like. CT scan, you all know, it's an excellent assessment. It gives for the bone contours. We take 5 mm thick or thin slice which are used, multiple planes are used, and reconstruction in various planes is possible. CT scan largely is used to assess fractures, stress fractures, growth plate fractures, neoplasms, infection, foreign bodies, OCDs, AVN, arthritis, and congenital abnormalities. You can also use 3D reconstructions which are not of much use in foot and ankle. This is how the axial, sagittal and semicoronal CT would look, and you would be able to learn about the geometry of the fracture, pattern of the fracture. That's the fracture lower and tibia, that's the calcaneus fracture, that's how you see Lisfranc in 3D. It is the axial cut across the tibiofibular interval and ankle mortise which would be of very much importance for syndesmotic evaluation, and this is how it would look on the CT scan. Nuclear medicine, yes, we do go in for that when you want to assess tumors, tumor-like conditions, metabolic disorders, some trauma, stress fractures, AVN, arthritis, infection, and RSD. And then you can use a 3-phase bone scan. Normally what is used is 99M technetium methylene diphosphonate. You can have various phases wherein you would have various patterns of the scans. Any area of increased activity, increased metabolic activity like a post-op hyperemia, infection, osteomyelitis, fracture, stress fracture would be picked up by the nuclear bone scan. Arthrography is used to assess articular anatomy, loose bodies, ligamentous integrity, capsular abnormalities, arthritis and tarsal collision, and there are various techniques. You can go in for the contrast or double contrast technique. It would tell you about the normal anatomy. It will also tell you patterns of extravasations whenever there are abnormalities. You can as well use angiography, venography for the specific cases where there is a suspicion of peripheral vascular disease or some venous or lymphatic problem. Ultrasound. I am going to talk more onto ultrasound and MR. Friends, I feel that ultrasound in our country is very, very important because it's a dynamic examination. You can examine the pathology, at the same time you can move the joint. It allows for direct palpation of painful areas during imaging. You always have an opportunity to compare it with the opposite side. And it is again very, very effective for the superficial structures like tendons and ligaments. So all of us must get ourselves trained to do our ultrasounds on our own, or train our radiologists to do our musculoskeletal ultrasonography. In next few slides I am going to show you where ultrasound is scoring over MRI. In MRI, what we have here is called as magic effect. Wherever a tendon takes turn acutely at the point, at the bony point, there are the chances where you will note your tears or tendinosis. But this is not possible to be seen unless you have a dynamic kind of MR. So unless you can plantarflex, dorsiflex the foot and take the MRA, you might miss on MR a tibialis posterior or peroneus longus or peroneus brevis tear, which is not so with the ultrasound. Okay, this is how the normal tendon in a longitudinal view would look like. Tendinosis would look like this. This is a partial tear. This is almost a complete tear. This is the image of Achilles tendon tear. Now, this is where the strength of ultrasound comes, you know. You can dynamically evaluate the gap in the tendon. You see, in the plantar flexion, the gap in Achilles is narrows down, and in a dorsiflexion, the gap widens to more than 2 centimeters. Peroneal tendon dislocation, you can see in the ultrasound, and in the ultrasound, the subluxating peroneal tendon could also be assessed when you do it at the hand. Whenever there is a hardware and you want to evaluate the tendon pathology, it is only the ultrasound which would be helpful. Like in this case, there is a screw put in at the lower end of the tibia, and this screw is impinging the tendon of the tibialis anterior. This could be very well delineated by ultrasound. Ligaments can also be seen. This could be, this is how you look for the anterior inferior talofibular ligament, normal, this is the injured one. ATFL, this is how it looks. This is the lateral examination. Herein it's an injured, I will go little fast. In the medial examination, you can see for the tendon, nerves, artery, ligament, the same way you can see with the MR. Posterior examination for tendons and Hager's fat pad. MRI gives excellent soft tissue visualization. More than 10 tendons cross the ankle joint, and transaxial plane would be most useful for evaluating the integrity of the tendon, and the pathologies like tenosynovitis, tendinopathy and tendon tears. So you can assess trauma, neoplasm, arthritis, AV and tarsal coalition and RST. And this is how the different signals would be seen, cortex, ligaments. I mean, I am not going into the details. Now, this is how the ankle ligament would be seen. This is the case wherein ankle ligaments are intact. This is the case wherein tenosynovitis of FHL is there. This is a soft tissue tumor, plantarwards. It's an example of thickened Achilles tendon. Again, bisected peroneus brevis, the subluxated peroneus, all can be demonstrated by the MRI. There is a case of osteomyelitis of calcaneus, and this is the interdigital neuroma, tarsal tunnel syndrome. Osteochondral lesion can be very nicely demonstrated by MRI, which is a limitation of ultrasound. Occult fractures can be detected like this through MR. But I am going to tell you the concept that MR plus ultrasound may be very important for you to use for detecting many of the ankle syndromes. See, this is how the MR in os trigonum would look like. This is the tarsal tunnel syndrome, MR as well as ultrasound both. This is how the tarsal tunnel syndrome and the ganglion would be seen. MR for Haglund's deformity and similar ultrasound. So friends, take home is that sometimes both MR and ultrasound may be required, and both of them are helpful for tendon and ligament pathology. MR is superior for osteochondral lesions and occult fracture. Ultrasound is superior for dynamic evaluation in a patient who has got a pacemaker or a hardware, and combination of both is best, and CT is superior for complex fracture. Thank you very much. That's all.
Thank you, Dr. Shah, for a very elaborate lecture on radiology. I think it's important to supplement imaging with your clinical diagnosis. Can I just reiterate again, I think we're still having mobile phone go off. Please switch them off or put them on silent at least to show some respect to the faculty. Senior faculty have already said it, so please do that. Can I now invite Mark Davis? The rest of the theme, as you can see on your program for the whole day, is trauma. And Mark will set the stage up for principles of management in foot and ankle trauma. And I can't emphasize enough, and he will talk us through how important it is to follow those principles to get the right results for your patients. Over to Mark.
Thanks, Mark. To basically go through some principles of management of trauma in the foot and ankle. So the aims are really to talk in general, and then to try and talk about some specific principles in this neck of the woods, some methods of fixation, and again to go along the lines of the surgical approach, as I said I would do earlier. I'm not going to talk about any non-operative management. I suspect that there are members of this audience that could talk to me and educate me a great deal about this. And I'm not going to cover any concepts of rehabilitation because it's beyond the remit of the talk. So, as always, it's really important to talk about the history and the violence of the injury, how much energy has been imparted to the patient. Is the injury an isolated injury? Is it polytrauma? It's important to know a little bit about the patient's background, their general health, whether they've got diabetes, have they been on steroids, is there a history of peripheral vascular disease, etc. Some patients may very well have had previous local trauma to the foot and ankle, and I think we're seeing this more and more often as patients survive higher energy injuries and live longer. Their social history is important. What do they do for their recreation? What's their job? Do they drink a great deal? Are they smokers? Anything about their pre-morbid mobility is important. Examination must be combined with the principles of ATLS, of which you'll be familiar with, and that's particularly pertinent for the high violence injuries. And this is a good case in point. You can see here, this is a person who has fallen off a bridge, and you can see there's a pelvic binder in place. These were open femoral shaft fractures that had been X-fixed, and there were tibial fractures bilaterally and open hindfoot fracture dislocations. But it's important to get the patient resuscitated in terms of their chest, their abdomen, their pelvis, any head injury, etc. And then this is all temporary stabilization. So this is temporizing the patient while they then settle down, and you can come back at another date to definitively do treatment. As I said, it's really important to examine them generally. Their mental test score is important, particularly in our elderly populations, the chest, abdomen, and their general neurology. Deformity is an important thing. It's worthwhile thinking about what you're actually seeing when you're seeing this deformity here, where the talus is desperately trying to get through the skin, and is compromising, it's blanching that skin. That skin is skin under threat. As is this here, this sort of typical extra-articular tongue-type calcaneal fracture, and the threat that it poses to the skin. This is within a few hours of injury. If that is left, that necroses. That's a very difficult piece of skin to then rescue using your plastic surgical colleagues. So deformity is important, and it may very well be an emergent thing that has to be treated. Clearly, open injuries are another urgent, emergent problem. Here we have an open calcaneal fracture, again a tongue-type of injury. Here we have an open Achilles laceration, and here the typical medial malleolar transverse open fracture pattern that we see day in, day out. All of this needs to be borne in mind. And it's important to think about neurovascular assessment. Here with this open talus, the neurovascular structures are going to be very, very stressed and strained over the deformity. They may very well have been compromised with that open injury. That needs to be taken on board. So just briefly to cap again, it's about airway and cervical spine safety, breathing, circulation, disability and exposure, the ABCDE that we all learn in ATLS. But combined with this at any stage will be general resuscitation. And then to think about damage limitation surgery. And more in the UK, we're going along the lines of thinking about the general health of the patient's clotting factors, their lactate level, their core temperature. If these three things are deranged, then this patient's prognosis is poor, and one shouldn't intervene with major long surgery if there's a threat to their life because these three factors are compromised. When this is all stabilized, that's the time to do your definitive fixation. So just to reiterate, the clotting, the lactate and the core temperature, those are three factors that have to be borne in mind. They have to be as near normal as possible if you're going to do lengthy surgery. Clearly, tetanus and antibiotic therapy, and some of the guidance that you will have locally here may not be pertinent to us in the UK and vice versa. So, urgent and emergent surgery. Well, this is the same picture from earlier, this horrible fracture dislocation of the hind foot with an open injury. And it's a question of taking the patient to the operating theatre, prepping them properly, excluding the foot, and lavaging, cleaning, getting rid of any of the debris that's in there. Reduce the dislocation, relieve that threatened skin, make it safe. It may be an external fixator, and then you can come back and plan your next step. And it's important when you're doing your washout of open injuries of the foot and ankle to increase the deformity. Put the foot back in the place that it was at the time when it became open. Because you can see there's some excellent information here. This is an open medial malleolus fracture. And look at that stripe of chondral damage where the talus has clouted the tibial plafond during the process. And then we sometimes wonder why these patients don't do well. They may never have got a postoperative infection from their open injury, but the chondrolysis that will happen from that is significant, and that is an image that you can document and tell your patient about. Remember to extend the lines of your incisions along lines that can be used by plastic surgeons. Involve your plastic surgeons early. Ask them to do some of your extensions if necessary. And then to think about temporary fixation. And I've deliberately put this one up here because this is appalling. This was one that was temporarily stabilized and sent to us. And you can see that effectively it's still acting as a hinged articulated fixator to try and stabilize a pilon fracture here. So it was totally inadequate. Remember the sequence of triangles. Triangles are very strong with a supporting strut here. That's a very strong, stable way of immobilizing your patient. But if they're in an external fixator, don't sit on your laurels because they can still subluxate in the fixator. Be vigilant. These soft tissues may not be settling because the fracture has redislocated with the fixator in situ. Once you have got your fixator in situ, it's very easy for you then to sit and scan and plan. So this was span, scan, plan. Nice sort of bit of rhyming words just to help you remember. So get them safe in an external fixator, and then, as Dr. Rana said, the CT is a really, really valuable tool for planning your fracture management. You get very, very clear pictures of the fracture pattern. It can help you determine your surgical approach. You may need to have other radiographic examination. You may want Broden's views, etc. And also, it may be that you're in a situation where you haven't got all the quite right kit to do your fixation, and when it's safe, you can use your scan to plan to get kit in. And then never forget the soft tissues. You want to do any combined procedures with your plastic surgical colleagues. Another thing to think about while you're waiting for definitive treatment: rest the limb, ice it, compress it, elevate it. You may find that foot pumps, etc., may be useful. Cryocuffs can be used, and some people are advocates of it. And then look for the signs of skin wrinkling, which we talked about earlier, and I showed you that picture. So then it allows you also to, with the soft tissue planning, is here we've got an open fracture dislocation of the hindfoot, and there's a large medial wound here and a smaller lateral wound here. Fixators in situ, you've got a hybrid of both small fixation and large fixation, but it allowed the plastic surgeons then to come in and think about a bipedical flap to cover both of those areas in one sitting. Another thing to think about is with the swollen foot, is here you can see this is a post-operative patient who's had a Lisfranc injury, a long longitudinal access to the first web space and the second metatarsal, and the foot was quite swollen, but it was an emergent case where the foot was threatening the skin. So all we've done here is just little puncturations through the dermis to allow effectively a split skin graft closure to allow the tension off the wound here. And that works quite nicely. We call it pie crusting. It's in the literature. It can be very helpful. So then some other specifics that we'll talk about, particularly when we come to the navicular and cuboid fractures, is the consideration of column length restoration. This is something that you'll be familiar with from the principles of club foot management. But remember, we have a lateral column here, which is clearly depicted, and then a medial column here. So this very rigid medial structure and a more accommodating lateral structure. And I think it's important to consider those two columns in terms of your reconstruction, making sure that you reconstruct the relative lengths of those columns. And then also some other principles, AEO principles, which we're again very familiar with. The idea of trying to achieve anatomical reduction of all intra-articular fractures, and then to get stable fixation, whether it be internal, external, or a combination of the two. And what we want to then do in terms of our rehabilitation, because we want early joint motion, we want weight bearing and better rehabilitation. And in our elderly patients, that's really important. We have to get them mobile. Internal fixation, well, clearly you can use a combination of plates and screws, as we've got depicted here. We find lock plating very useful here. This was a column restoration because of a midfoot fracture dislocation. And the lock plating acts as an internal-external fixator. It keeps those columns out to length. Yes, they're spanning the joints, but you can remove them then, and you have a reconstructible foot that is not going to go into planus or valgus or to collapse. Consider internal fixation using a hindfoot nail. This may be very barbaric, but you can see here, this is very osteopenic bone. There's an awful lot of crushing here of the metaphysis. That's going to be difficult to get decent internal fixation in. And this was a patient who doesn't have a great deal of mobility, and a hindfoot nail allowed us to let the soft tissues to settle, to permit weight bearing, and to get fracture union. External fixation. The soft tissues may never settle. So you're going to have to rely on external fixation here for an open cuboid fracture with crushing. This was the only way that we were going to maintain column length, was to consider quite an elaborate set of triangles here. And sometimes a combination of the two. You see here internal fixation for this Lisfranc with both columns spanned out with external fixation. It was a way to maintain the column lengths. And on this example here, with the talus, massive crushing of talar neck with a screw keeping the length out by bridging into the navicular, and then external fixation as the definitive management. As I said, traction, plaster casts and functional braces may be considered, but that's beyond the remit of this talk. And think about your approach. Think about the swelling. What's that going to dictate for your approach? Think about skin loss. Think about the blistering. We saw the picture earlier about the calcaneal fracture with the lateral skin blistering. Think about your fracture patterns. Think about where the maximal displacement of those fracture patterns are, and think about internervous planes. So we're all familiar with the anterior approach of Henry. I've talked earlier about the anteromedial approach to the ankle and talus, and also this one here. Medial approach to the malleolus, well, that's bread and butter. But consider the medial malleolar osteotomy. And more importantly, consider using the fracture that you're given by the patient. That is already some dissection that has been done. There's no point in doing anything more. Lateral approach to the fibula we're all familiar with, and then consider the posterolateral approach to the ankle. Quite often in ankle fractures, the posterolateral skin doesn't blister. I don't really understand why that's the case, but it is a way in to fixing difficult and unstable fractures. And it may even be able to do it percutaneously. Occasionally I use a posterior medial approach to the ankle, and that again is dictated by what I find on the CT scan and the amount of comminution that I find on the posterior malleolus. Consider a lateral malleolar osteotomy, particularly for approaches to the lateral talar dome, but it can be for removing debris. And the dorsal approach to the foot in line with the second ray. So medial malleolar osteotomy, as literature has developed, this has gone from being just simply taking off the malleolus here to getting more and more extensive to give you great views of the plafond. And in this instance here, you can see there are screws already across the anterior aspect of the anterolateral plafond, because that was where a fracture line was. So again, use what you're given by the patient. And use the medial malleolar fracture to get it out intra-articular fractures that you can see here. You may even be able to fix an osteochondral defect through that medial malleolar fracture. That's well worth considering. So the posterolateral approach to the ankle, this isn't anything new, but it has been written up by myself and one of our fellows in current orthopedics, and effectively it's the same approach as the volar approach to the wrist, which everyone is so familiar with. This is the same way of dealing with an ankle. And it is to develop the plane here between the belly of FHL and the peronei, and if you reflect that medially, then that gives you really good access to the posterolateral part of the posterior malleolus. And then you can move the peronei that way, and you can get to the back of the fibula, which is a flat surface and is usually easier to plate from there. The only difficulty can be dealing with the medial malleolar fracture. So here is an intraoperative picture. You can clearly see that classic inverted V sign of the posterior malleolus, very easy to see there, and then buttress plating to it. Nice stable fracture. It does allow you to get the ankle rehabbing very early. Use of the lateral malleolar osteotomy. Well, here we have, it's not very clearly projected, but you can see a double sign, a double shadow, if you like, of the lateral talar dome. Osteotomize the fibula, and that allows you to get in here. So the idea of using the maximal fracture fragment displacement philosophy is something that we use a bit in Sheffield. And it came from Pelon fracture management and some studies that were done in Bristol. And the idea is that where the fractures are mostly displaced is where the soft tissue damage will be at its greatest. So in this section here, that's where the biggest gap is. That's where you should aim to make your skin incision. If you just came through your anterior approach of Henry, you'll have to devascularize in order to access that fracture. So the way we tend to do it is to get some needles and put them in line along that fracture line, find the fracture line, get the fracture hematoma, and then incise along the length of the needles, and that allows you to reconstruct here. And that's quite a good idea here in the Pelon, but I also use it for my talus fractures. So we're talking about whether to use an anteromedial or an anterolateral approach. I think a large part of it is governed by the fracture fragment displacement, and you can use that philosophy for the same reason. And it makes sense, because that's why we use the medial malleolus if it's fractured for our approaches anyway. So there's the internal fixation as afforded by that approach. So to summarize, we've brushed upon some general trauma considerations, a bit about timing and what will govern the immediacy of treatments and indications. I've tried to stress the importance of the soft tissues and to give you a little bit of the idea of methods of fixation, and that it's perfectly reasonable to extrapolate the values of AO and to use internal, external fixation and combination techniques. And to give you an idea of thinking about choosing your surgical approach, not necessarily by just thinking about what you've learned from a book, but to consider about the philosophy of soft tissue management. Thank you.
Thank you, Mark, for an excellent talk. Can I invite Dr. Shah back up here and also Ms. Allen? We're ready to take any questions, any comments, anything from this morning. And please switch your mobiles off. Are there any questions? Yeah. Any comments will do from this morning? Yeah. There's a mic there if you want to say.
I am Dr. Devdatta Chatterjee from Kolkata. Thank you very much for all the speakers for their excellent talk. My first question to Dr. Henderson, that it is just a comment that you have said that we have to ask the patient in this toe. We call it toes, not the fingers. In your slide, you have said that how are your fingers in one of your slide. Most likely it is a we call it in foot, we call it toes probably, as far as my knowledge is concerned. In your slide, it is printed as a fingers.
Can I, can I just say something?
Yes.
Sorry, obviously we got Mark Davis rather than Mr. Henderson because he couldn't make it. Mark, I can't remember if he had any fingers on there. I saw toes. So
what he said was, ask patient to put the finger where the pain or the problem is.
All right,
he never said toes. He never said.
Oh, all right. I mistakenly taken the point. Right. I'm sorry. Now to Dr. Rajiv Shah, that in this dimensions, that is these distances, there's 3 millimeter, 1 millimeter, all we know, but most of we see in the conventional X-ray. Any comment about the digital X-ray, whether this percentage of this?
Very valid point, you see. In the digital X-rays, they ought to reduce the size, they ought to increase the size. So for you, for getting the perfect size, and when you want to really see the parameters, 2-3 things are very important. Number one, the distance between the tube and the foot. Number two, all the images should be given as true size image. So you could just, I would mention to my radiologist to give me a true size film, and that solves the problem.
Any other questions?
Yeah, there's a question for Dr. Mark. Do you use pressure lavage in compound injuries? Do you routinely use them or use it, or?
It's a good question. We used to routinely use pressure lavage until about 3 or 4 years ago, and the vogue now from our trauma surgeons is that we should just use unpressurized solutions, partly because we're worried it's going to further embed any contamination into the soft tissues, and I think that's largely true. But I think the lavage is obviously a big part of it. I think it's very important to expose and to increase the deformity back to where it was to gain you the best access, and then I don't think as long as you lavage thoroughly, it probably doesn't make a great deal of difference. But to answer your question, yes, we've gone away from pressurized lavage.
All right. Another question about medial malleolus osteotomy.
Yeah.
How far laterally can you go with the entry into the joint with the osteotomy? And if you go in much more laterally, you find it difficult to flip the fragment down to expose the talus properly. So how would you do? How far can you go laterally on that?
I don't think I'd ever go across the sagittal midline of the talus, because I think you're quite right, that would be a problem. There's been a couple of decent papers in Foot and Ankle International over the last 5 years, and they seem to be keeping to the medial side of that line.
All right. Thank you.
I just wanted to add a few points onto the management of foot and ankle trauma. Typically, wherever this talk I deliver, I talk about 12 commandments of foot and ankle trauma. majority of them were largely covered, but few of them which I think you all people who deal more with the trauma would be worthwhile pointing to. Very important commandment is you need to have high index of suspicion while managing foot and ankle trauma. Very, very important. Talus fracture, think that yes, is it really undisplaced? So use very high index of suspicion in foot and ankle trauma. Unresolved ankle sprain, think of something else. There has to be something which is not fitting into the situation. So high index of suspicion is one very, very important commandment one has to take into mind whenever a person is dealing with foot and ankle trauma. The another important one is precise and judicious use of radiology, which I delivered into my talk. The important third commandment would be maintenance of the arches. Your aim while treating foot and ankle trauma is to give plantigrade foot so that your patient is not putting more weight or less weight onto one part and then patient is coming back to you with the cons and callosities and pressure areas. You need specialized instruments and equipments. They are not the luxury in your armamentarium, they are the must. The last and importantly, the foot and ankle trauma post-op care and post-op physiotherapy is not same as we do with the general trauma. Sometimes for the midfoot injuries, after removal of the splintage or after removal of your cast, you would need to give arch support to your patient for good amount of period, and then if you don't do, your nice fixation would just give way. The screws, plates, you might need to plan to remove it, or you might need to inform your patient, otherwise he will come with the breakage of the screw and you would be blamed. And physiotherapy essentially is different than what we do. We have to focus more onto eccentric physiotherapy, eccentric strengthening and TheraBand. So these are certain differences which we need to take care while you are dealing with the foot and ankle trauma. And to add one more, whenever you are putting incision into midfoot and forefoot, put a very gentle incision. Take a hemostat and separate the incision out. Otherwise, if you put a deep incision like we do for the femur and tibia, you are going to damage the cutaneous nerves and your good work would be spoiled by the neuroma. So these are certain important facts one needs to take care when you are dealing with the foot and ankle trauma. The management of foot and ankle trauma is absolutely different than what we do elsewhere. Thank you.
Thanks very much. Are there any other questions? We've got coffee. We are running a little bit late, as you all know, because we started a little bit late, but the speakers have kept to time, and I can only thank them for that. Can we have a round of applause for an excellent session by the speakers this morning? Can we have coffee next for about 15 minutes, and I will urge you to be back in 15 minutes, please, so that we can keep to time. Thank you.
Today, can I ask you all to join us in wishing him a very happy birthday?
Thank you. Getting old, another year old. The next section is on ankle fractures and peel-on, and we all know that that's one of the commonest injury, particularly the ankle fractures that we treat in our day-to-day practice. And the way it's structured is Mr. Blundell is going to cover principles of ankle fractures, how to manage them, and particularly sort of elderly people, difficult situations. And I'm going to throw in some controversies and get some of the faculty as well as delegates to contribute to it. So you'll be put on the spot, be ready for it. And then Dr. Rana is going to cover peel-on fractures. And if time permitting, we've got a couple of really good cases, and I would quite like to throw those in for some interaction from the delegates and faculty right at the end. So please welcome Mr. Chris Blundell, who's going to talk about ankle fractures for us.
Morning, ladies and gentlemen. Thank you very much, JIT and the organising faculty for inviting us as sort of representatives of the British Orthopaedic Foot and Ankle Society to come and run this course in conjunction with your local faculty. Just click forward. Point it. Okay, that's fine. Got it. Thank you. Can I ask you all to make sure your phones are switched off, please, and on silent? I find my talk will stop if people use the phone because I'm not very good at concentrating on two things at once. Can you all please complete your feedback forms as the talks go on? I think that's a very useful thing. We need to know whether what we're talking about is of any value to you or not, and the only way we'll know that is if you tell us on the feedback forms. So I'm going to talk about ankle fractures. And we've got a few objectives. So the first is to talk about what exactly is the problem, a little bit about anatomy and biomechanics. We're going to talk through some classifications because I think that's important in terms of guiding how we're going to manage ankle fractures. Pivotally, we need to discuss what is a displaced and undisplaced and what is a stable and what is an unstable ankle fracture. We'll go through some of the specific features that are pertinent to ankle fractures. And then, as Jit said, we're going to touch on ankle fractures in the elderly and a brief mention of diabetic ankle fractures. So in the UK, ankle fractures represent about nearly 200 ankle fractures per annum per 100,000 of the population. So in India, that represents in excess of 2 million ankle fractures a year. Assuming that your injury patterns are similar to ours, you probably actually have more than that. In the UK, we have more men fracture their ankles than ladies. I don't know what the situation is in India. But I suspect that across the world, around 1 in 10 patients who turn up to an emergency department have got an ankle fracture. And we know that the incidence in terms of the prevalence of ankle fractures and the severity of ankle fractures is increasing. And that's increasing because of increasing comorbidities in terms of age, weight, smoking, and medical comorbidities. And about 3/4 of the ankle fractures that pitch up are stable, and about 1/4 are unstable. So just to review the anatomy again, what obviously is very important when you're talking about ankle fractures is the ligaments around the ankle. So just to make sure we're all talking the same language, this is the anterior inferior tibiofibular ligament holding the fibula to the tibia. And some people have recently started calling this the anterior syndesmotic ligament, which I think is quite a nice term because that's exactly what it is. In contrast to this ligament here, which is the anterior talofibular ligament, which conveys ankle stability. And these ligaments around the lateral side of the ankle are pretty important too. The calcaneal fibular ligament particularly is very much involved in ankle fractures. And on the medial side, of course, the principal structure we're interested in is the deltoid, having both superficial and deep parts, with the deep part here going into the talus and the superficial parts coming down onto the navicular and onto the sustentaculum tali. Posterior view Mark's already shown you a posterior approach to the ankle, and I'll mention that as well, but I would very much encourage everyone here to think about the posterior aspect of the ankle in terms of fractures and surgical approaches. So we all get a little bit hung up on classifications in the UK. I suspect you guys get pretty hung up on classifications too, and really I'm only going to talk about these two classifications because they're really the only two that are of any value. So the Weber classification, which is what we all learn when we're interns and med students, is very straightforward and is very useful. A Weber A fracture is generally a stable fracture that occurs below the level of the syndesmosis. A Weber B fracture is one that crosses the syndesmosis and is always best seen on a lateral view, and usually an oblique fracture like that, and often the AP disarmingly looks normal. And a Weber C fracture is one which is above the syndesmosis and confers particular aspects of syndesmotic stability. What about Lau-Hansen's classification? Well, I confess to tell you that I find this rather confusing, and I'll try to clarify it as we all go so we all get this together. There are two words on the Lau-Hansen classification. The first word refers to the position that the foot is in at the time of the injury, and the second word refers to the deforming force which has caused the injury. So supination external rotation, for example, is a supinated foot which then has external rotation applied to it. Pronation abduction is a pronated foot when an abduction force is applied. I'm not going to talk about pronation dorsiflexion. So Lau-Hansen described this more than 60 years ago based on cadavers. Remember that the injury starts on the tight side of the ankle. So what I mean by that is that if you've got a supinated foot, and if you put your own foot in supination under your seat there, you'll realize that the structures which are tight are the lateral structures. And that tells you what's actually going to injure in a supination injury. And in pronation, it's the medial structures which are tight, which again tells you what's going to be injured in your pronation abduction type of injury. So there are several stages to each of these as well. So we've got 4 classifications which are each broken down into a series of stages which are incremental levels of severity of injury. But not every fracture fits into every category, and that's always a failure of every classification system in my mind. So if we look at the most common, and this is by far and away the most common, this is about 3/4 of ankle fractures that you will see are supination external rotation injuries. And the 4 stages are down there on the right. So in the first stage, which is the most mild of injuries, it's this anterior syndesmotic injury which is injured. So that's the anterior inferior tibiofibular ligament. And in stage 2, the fibular fractures. So that's, in reality, they're the ones that you'll actually see most frequently, because the patients that will come to you are the ones where there's actually been a bony injury as opposed to a soft tissue only injury. And in stage 3, this injury pattern has gone round the back of the ankle, and either the posterior malleolus is fractured or the posterior tibiofibular ligament has been injured. And in stage 4, you've got a medial injury. And be careful here, because look at stage 3, there may not be a fracture, so it could be soft tissue only. And in stage 4, there may not be a fracture, it may be soft tissue only. So you can have a posterior tibiofibular ligament injury, and you can have a deltoid ligament injury, and the only thing you're going to see on the X-ray is a fibular fracture. Okay, so be careful that you may only see on a plain film a fibular fracture when this could be a much more severe injury or a very mild injury. Supination adduction. So again, twist your foot so that you're supinated. Harry?
Can't see it.
What's happened? When did it go? Just now. The black screen of death. I can see it. I think in the UK, foot and ankle experts would tend to use Lau-Hansen, and I think most of our junior registrars would use Weber classification. And I think the reason that Lau-Hansen is important is not that I don't think that you're able to classify every fracture according to Lau-Hansen, but that you understand the mechanisms involved so that you can understand that Weber doesn't tell you everything. Okay, so we're good to go. So supination adduction. So you're going to put your foot under the chair there in front of you and just supinate it, and you'll feel that the structures that are tight are on the lateral side. If you then adduct forcibly, then the injury pattern you're going to have is a transverse fracture of your fibula, which is below the mortise, and you're going to end up with a vertical shear type pattern on the medial side. One of the important things about these fractures that you'll see quite often is that they are unstable, and that quite often there's a chondral injury in the medial aspect of the ankle joint where that blue arrow is pointing. Hopefully the blue arrow is pointing. Third type is your pronation external rotation. So this time the foot, rather than being supinated, is pronated. And these tend to be a more uncommon injury pattern because the foot, as it hits the ground, is generally supinating at the point of heel strike, and therefore your injury tends to be on a supinated foot. But a pronated foot with external rotation goes through these 4 stages again, which you'll recognise as being your supination external rotation the other way round. So these injuries start on the tight side. So like we said, pronated foot's tight on the medial side. So your injury starts on the medial side, and it starts with either a deltoid ligament injury or a medial malleolus fracture. Your stage 2 then goes round through the anterior inferior tibular-fibular ligament again, spiral fracture of the fibula, and your stage 4 now is your posterior malleolus fracture or your posterior tibiofibular. So it is quite literally supination external rotation the other way round. Pronation abduction then, so again, foot is tight on the medial side, so your injury pattern starts medially, and this time it's an avulsion pattern, just like your abduction in a supinated foot is a transverse fracture. Again, you have a transverse fracture of the medial malleolus now, because that's fractured under tension. The deltoid avulses the tip of the medial malleolus. Posterior malleolar fracture may occur, or it may be again this posterior tibiofibular ligament, and it's your last stage when you see the fibular fracture, which is classically above the syndesmosis. So these are your classic Weber C fractures. So it's pretty important that when you're looking at these patients that you get a history of what happened. We've heard that earlier from Trish's talk and others, that it's vital to understand from the patient what actually happened to them, because that will give you an idea of the violence that's been applied to the ankle. From a physical examination point of view, you're looking for swelling, blisters. You want to get from your history essential comorbidities. Is this a diabetic patient? Is this a smoker? Is this a patient who's got significant comorbidities that may influence how this fracture is going to behave or how I'm going to manage that fracture? We've heard lots about imaging earlier. I won't talk further about that. This is the pivotal thing. Is it stable or is it not? So do I need to fix this? Well, in order to figure that out, you need to figure out what a normal X-ray looks like. Well, I make no apologies for reiterating what we heard earlier on. I think repetition is the art of learning. So these are the things we're looking for, and each of these colours tells you what these things are. So the little red arrow there is your tibiofibular overlap, and less than 10 millimetres is normal. The blue line is what we were hearing about earlier, which is your tibiofibular clear space, and again, exactly like we heard before, more than 5 millimetres suggests some disruption between the fibula and the tibia. And the Tailor tilt obviously indicates that there's some degree of instability on either the medial side or the lateral side. And although more than 2 millimetres is considered abnormal, I think those lines should be parallel. And if those lines aren't parallel, you need to think about why they're not parallel. And it may be that it's a normal variance and you need to x-ray the other side, or it may be that there's a relatively subtle occult injury. The Mortise View is what we all hear about and know about. It's very, very important to do a Mortise View because this is what will tell you about those lines we were just looking at. And in terms of the medial clear space, I heard someone say before about digital imagery. And I have a bit of a problem with measuring things with rulers in millimetres, but usefully the medial joint space should be pretty much the same as the dorsal joint space. So that was our hearing earlier about Shenton's line, wasn't it? So Shenton's line should show you that the medial clear space is pretty much the same as the weight-bearing dorsal space. If you've got less than 1 millimetres of overlap, there's a problem here, and this is a syndesmotic injury. And I think a useful rule of thumb is that you should never see fresh air between the fibula and the tibia at the ankle joint. If you can see fresh air, you know, if you can see a clear space between those two, that's not right until proven otherwise. What about these soft tissue signs? Do they help us decide what's stable and what's not stable? Well, there were two very nice studies published about 5 years ago, back to back, looking at assessments of medial tenderness, bruising and swelling, and seeing whether they conferred stability in the classic supination external rotation injuries. So the simple answer is a series of signs here which says no, they don't. So in a nutshell, medial swelling doesn't have any correlation between the severity of the injury in terms of stability. Sorry. What does matter? Well, we were hearing before about doing a stress radiograph. And a stress radiograph can either be done this way, i.e. you hold the patient and you externally rotate the ankle and you do a Mortise View, and apparently you're supposed to apply 8 pounds of force. Now, I don't know who in this room can figure out 8 pounds of force from his arms. I can't. But you twist it fairly hard until the patient won't let you twist it anymore and x-ray them. That's one way. But a nicer way was what we heard about earlier, essentially, which was a gravity stress view. And that's been published and validated as being an assessment of stability by shock 6 years ago, and it's very comfortable. It doesn't hurt the patient at all to do this. And if you look that the medial clear space widens, that ankle joint is unstable. It needs treatment. Like I said before, you've got to be very careful. This is a supination external rotation type 4, and on that view, really, unless you're looking very, very carefully, a lot of people would just say this is a fibular fracture and that it's unstable because you've got an increase in the medial clear space. But you must remember that the only fracture here is lateral, but we know that in order to have done that, there has to have been a soft tissue injury at the back, there has to have been a soft tissue injury on the deltoid side. So this is an unstable, severe injury, but the only bony injury appears to be a fibular fracture. So what's the definition of a stable ankle? Well, a stable ankle clearly is one in which the talus is congruent within the mortise. It's stable if the deep deltoid is intact. Clinically, does a lack of medial pain, swelling, bruising or tenderness mean that this is stable? Well, we know it doesn't. You can investigate them with stress radiographs. I think that's a really useful thing to do. We were hearing before about ultrasound. I'm sure that's a very, very useful tool, though there are actually no studies which talk about ultrasounding ankles to confer whether an ankle fracture is stable or not. No one's done that study yet. It needs to be done. If the patient's wandered around on this ankle and the first x-ray you've got are of a congruent talus in the mortise and the patient's walked around for a few hours or a few days, that ankle's probably stable. They've done their own stability tests. So a stable ankle is one in which there's a low chance of secondary displacement, and therefore your treatment for them can be relatively straightforward. Brace them, perhaps a focused rigidity type of cast, and I don't think you need to worry about the patient's weight bearing, and you don't really need to worry about further imagery if you truly believe this ankle fracture is stable. So use your resources wisely. You don't need to x-ray these patients every week because you know this is a stable fracture. It's about a quarter of ankle fractures are displaced, however, and are unstable. If they're unstable, you've got to reduce that fracture and confer stability to it. So here we go, patient who's had a fracture dislocation. That fibular fracture you can see is comminuted, and this patient's pitched up, having already told the A&E department that her ankle was dislocated. And the first x-ray you get is of an ankle that looks like it's, well, it might be moderately reduced, but it clearly isn't really. If you look at this x-ray here, there's the posterior malleolus, here's the anterior part of the mortise here, and that's grossly displaced. So be very careful and vigilant when you're looking at your x-rays, please. So what do? Well, span, scan, and plan, like Mark said. So in a relatively high energy, unstable ankle fracture like that lady, she needs to get her soft tissues organised. We need to let the soft tissues settle. She doesn't need an operation today. She's probably got a very swollen ankle. Her x-rays in her cast show the mortise is reasonably reduced. You can keep taking that plaster off and looking at the soft tissues every day, and every time you take that plaster off, you might redislocate her, and in fact she will redislocate. So we tend to put a very simple, inexpensive spanning fixator on, because we know then that they're reduced and that they're going to stay reduced. You can then scan them if you want to scan them. I think someone's talking a little bit about CT scanning. I think Jit's going to talk about CT scanning as a controversial subject, but we do scan them in Sheffield, and they come up with a plan for fixation. So she has a spanning fixator put on. That ankle is stable. The posterior malleolus looks better. The talus is reduced under the tibial plafond, which is what we need to do, and we can sit tight and comfortably, and we can not fret too much about that patient whilst her soft tissues settle. Subsequent to that, we can fix her. Okay. The medial malleolus is an interesting area, which is often rather ignored, to be honest, but is very important. And Herskovich classified these in A, B, Cs, and Ds, as you can see. I would suggest really think carefully about vertical shear fractures. There are four armamentarium of fractures that you can't just treat with a pair of screws necessarily, because that medial malleolus is trying to migrate proximally all the time. And unless you put your screws in exactly the right place, that medial malleolus can continue to migrate proximally and probably needs buttressing or transverse screws perpendicular to the fracture line. With your little low fractures of the medial malleolus, when you think there's just a relatively small avulsion fracture, just remember that the deltoid takes origin from both the front and the back of the medial malleolus, and that the deep part of the deltoid comes from the posterior colliculus, and the superficial deltoid comes from the anterior part of the colliculus. So be very careful if when you open the medial malleolus, you find your medial malleolus is bivalved into